This is a review from class, Nursing Assessment, Cardiovascular System, Chapter 32 of the Lewis textbook. The heart is a four-chambered hollow muscular organ, normally the approximate size of a fist. It lies within the thorax in the mediastinal space that separates the right and left pleural cavities. It's composed of three layers: a thin inner lining, the endocardium, a layer of muscle, the myocardium, and an outer layer, the epicardium. The heart is covered by a fibrous serous sac called the pericardium and consists of two layers: the inside, which is the visceral layer of the pericardium, also known as the epicardium, and the outer layer, which is the parietal. A small amount of pericardial fluid, approximately 10 to 15 mL, lubricates between the pericardial layers, which is the pericardial space, and prevents friction between the surfaces as the heart contracts. The heart is divided vertically by the septum. The interatrial septum creates a right and left atrium, and the interventricular septum creates a right and left ventricle. The thickness of the wall of each chamber is different. The atrial myocardium is thinner than that of the ventricles, and the left ventricular wall is 2 to 3 times thicker than the right ventricular wall. The right atrium receives venous blood from the inferior and superior vena cava and the coronary sinus. The blood then passes through the tricuspid valve into the right ventricle. With each contraction, the right ventricle pumps blood through the pulmonic valve into the pulmonary artery and to the lungs. Blood flows from the lungs to the left atrium by way of the pulmonary veins. It then passes through the mitral valve and into the left ventricle. As the heart contracts, blood is ejected through the aortic valve into the aorta and entering systemic circulation. The four valves of the heart serve to keep blood flowing in a forward direction. The cusp of the mitral and tricuspid valves are attached to thin strands of fibrous tissue termed chordae tendineae. The chordae are anchored in the papillary muscles of the ventricles. This support system prevents eversion of the leaflets into the atria during ventricular contraction. The pulmonic and aortic valve, also known as semilunar valves, prevent blood from regurgitating into the ventricles at the end of each ventricular contraction. The myocardium has its own blood supply, the coronary circulation. Blood flow into the two major coronary arteries occurs primarily during diastole, which is relaxation of the myocardium. The left coronary artery arises from the aorta and divides into two main branches, the left anterior descending artery and the left circumflex artery. These arteries supply the left atrium, the left ventricle, and the interventricular septum, and a portion of the right ventricle. The right coronary artery also arises from the aorta, and its branches supply the right atrium, the right ventricle, and a portion of the posterior wall of the left ventricle. The AV node and the bundle of His are part of the cardiac conduction system and receive blood supply from the right coronary artery. For this reason, obstruction of this artery often causes serious defects in cardiac conduction. The divisions of the coronary veins parallel those of the coronary arteries. Most of the blood from the coronary systems drain into the coronary sinus, which empties into the right atrium near the entrance to the inferior vena cava. The conduction system is specialized nerve tissue responsible for creating and transporting the electrical impulse or action potential. This impulse starts depolarization and subsequently cardiac contraction. The electrical impulse is normally started by the sinoatrial node, which is also known as the pacemaker of the heart. Each impulse coming from the SA node travels through the interarterial pathways to depolarize the atria, resulting in a contraction. The electrical impulse travels from the atria to the AV node through internodal pathways. The excitation then moves through the bundle of His and the left and right bundle branches. The left bundle branch has two divisions, anterior and posterior. The action potential moves through the walls of both ventricles by means of the Purkinje fibers. The ventricular conduction system delivers the impulse within 0.12 seconds. This triggers a synchronized right and left ventricular contraction. The result of the cardiac cycle is the ejection of blood into the pulmonary and systemic circulation. It ends with repolarization when the contractile fiber cells and the conduction pathway cells regain their resting polarized condition. Cardiac muscle cells have a compensatory mechanism that makes them unresponsive or refractory to restimulation during the action potential. During ventricular contraction, an absolute refractory period occurs, during which cardiac muscle does not respond to any stimuli. After this period, the cardiac muscle gradually recovers its excitability and a relative refractory period occurs by early diastole. The electrical activity of the heart can be detected on the body surface using electrodes and is recorded on an electrocardiogram. The letters P, QRST, and U are used to identify the separate waveforms. The first wave, P, begins with the firing of the SA node and represents depolarization of the atria. The QRS complex represents depolarization from the AV node throughout the ventricles. Impulse transmission through the AV node is delayed, which accounts for the time interval between the end of the P wave and the beginning of the QRS wave. The T wave represents repolarization of the ventricles. The U wave, if seen, may represent repolarization of the Purkinje fibers, or it may be associated with hypokalemia. Intervals between these waves, PR, QRS, and QT intervals, reflect the length of time it takes for the impulse to travel from one area of the heart to the other. These time intervals can be measured, and changes from these time references often indicate pathology. Depolarization triggers mechanical activity. Systole, contraction of the myocardium, results in ejection of the blood from the ventricles. Relaxation of the myocardium, the diastole, allows for filling of the ventricles. Stroke volume is the amount of blood ejected from the ventricle with each heartbeat. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. It is calculated by multiplying the stroke volume by the heart rate. For a normal adult at rest, cardiac output is maintained in the range of 4 to 8 liters a minute. Cardiac index is the cardiac output divided by the body surface area. The cardiac index adjusts the cardiac output to the body size. Numerous factors can affect either the heart rate or the stroke volume, and that affects the cardiac output. The heart rate, which is primarily controlled by the autonomic nervous system, can reach as high as 180 beats a minute for short periods without harmful effects. The factors affecting the stroke volume are preload, contractility, and afterload. Increasing preload, contractility, and afterload increases the workload of the myocardium, resulting in increased oxygen demand. The volume of blood in the ventricles at the end of diastole before the next contraction is called preload. Preload determines the amount of stretch placed on myocardial fibers and can be increased due to a number of causes such as myocardial infarction, aortic stenosis, and hypervolemia. Contractility can be increased by epinephrine and norepinephrine released by the sympathetic nervous system. Increasing contractility raises the stroke volume by increasing ventricular emptying. Afterload is the peripheral resistance against which the left ventricle must pump and is affected by the size of the ventricle, wall tension, and arterial blood pressure. If the arterial blood pressure is elevated, the ventricles will meet increased resistance to ejection of blood, increasing the work demand. Eventually, this results in ventricular hypertrophy, which is an enlargement of the cardiac muscle tissue without an increase in cardiac output or the size of the chambers. Arteries carry oxygenated blood away from the heart, except for the pulmonary artery. Veins carry deoxygenated blood toward the heart, except for the pulmonary veins. Small branches of arteries and veins are arterioles and venules, respectively. Blood circulates from the heart into the arteries, arterioles, capillaries, venules, and veins, and then back to the heart. The arterial system differs from the venous system by the amount and type of tissue that makes up arterial walls. The large arteries have thick walls that are composed mainly of elastic tissue. This elastic property cushions the impact of the pressure created by the ventricular contraction and provides recoil that propels blood forward into the circulation. Large arteries also contain some smooth muscle, such as the aorta and the pulmonary artery. The innermost lining of the arteries is the endothelium, and the endothelium serves to maintain hemostasis, promote blood flow, and under normal conditions inhibits blood coagulation. When the endothelial surface is disrupted, like rupture of an atherosclerotic plaque, the coagulation cascade is initiated and results in the formation of a fibrin clot. Capillaries are made up of endothelial cells with no elastic or muscle tissue. The exchange of cellular nutrients and metabolic end products takes place through these thin-walled vessels. Capillaries connect the arterioles and the venules. Veins are large diameter, thin-walled vessels that return blood to the right atrium. The venous system is low pressure, high volume. The The larger veins contain semilunar valves at intervals to maintain the blood flow toward the heart and to prevent backward flow. The amount of blood in the venous system is affected by the number of factors including arterial flow, compression of veins by skeletal muscles, alterations in thoracic and abdominal pressures, and the right atrial pressure. The largest veins are the superior vena cava, which return blood to the heart from the head, neck, and arms, and the inferior vena cava, which returns blood to the heart from the lower part of the body. Regulation of the cardiovascular system is the autonomic nervous system, baroreceptors, and chemoreceptors. The autonomic nervous system consists of the sympathetic nervous system and the parasympathetic nervous system. Stimulation of the sympathetic nervous system increases the heart rate, the speed of the impulse conduction through the AV node, and the force of atrial and ventricular contractions. Also, stimulation of alpha-1 adrenergic receptors in vascular smooth muscle results in vasoconstriction, increasing the blood pressure. Stimulation of the parasympathetic system, mediated by the vagus nerve, slows the heart rate by decreasing the impulse from the SA node and conduction through the AV node. The parasympathetic nervous system is the brake that is activated during relaxation and regeneration. A properly functioning parasympathetic nervous system is essential for health, as a strong parasympathetic nervous system facilitates regeneration and has anti-inflammatory effects. Baroreceptors in the aortic arch and carotid sinus are sensitive to stretch or pressure within the arterial system. Stimulation of these receptors can lead to volume overload and sends information to the vasomotor center in the brainstem. This results in temporary inhibition of the sympathetic nervous system and enhancement of the parasympathetic influence, causing a decreased heart rate and peripheral vasodilation. Decreased arterial pressure then causes the opposite effect. Chemoreceptors are located in the aortic and carotid bodies and the medulla. They are capable of causing changes in the respiratory rate and blood pressure in response to increased arterial CO2 pressure, hypercapnia, and to a lesser degree, decreased plasma pH, acidosis, and arterial O2 pressure, hypoxia. When the chemoreceptors in the medulla are triggered, they stimulate the vasomotor center to increase the blood pressure. The arterial blood pressure is a measure of the pressure exerted by blood against the walls of the arterial system. It's measured by auscultating the sounds of turbulent blood flow through the compressed artery, which is termed the Korotkoff sounds. The brachial artery is the recommended site for taking a blood pressure. The systolic blood pressure is the peak pressure exerted against the arteries when the heart contracts. The diastolic blood pressure is the residual pressure in the arterial system during ventricular relaxation. The blood pressure is usually expressed as a ratio of systolic to diastolic pressure. The two main factors influencing blood pressure are cardiac output and systemic vascular resistance. Systemic vascular resistance is the force opposing the movement of blood, and this force is created primarily in small arteries and arterioles. Systolic blood pressure can be assessed using a Doppler ultrasound flow meter. The handheld transducer is positioned over the artery, which is identified by audible pulsatile sounds. The cuff is applied above the artery, inflated until the sounds disappear, then another 20 to 30 millimeters of mercury beyond that point. The cuff is then slowly deflated until sounds return. This point is the systolic blood pressure. Pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. It is normally about 1/3 of the systolic blood pressure. So if the blood pressure is 120/80, the pulse pressure is 40. An increased pulse pressure may occur during exercise or in individuals with atherosclerosis of the larger arteries as a result of increased systolic blood pressure. Decreased pulse pressure may be found in heart failure or hypovolemia. The mean arterial pressure refers to the average pressure within the arterial system that is felt by the organs in the body. It is not the average of the diastolic and systolic pressures because the length of diastole exceeds that of systole at normal heart rates. The mean arterial pressure is calculated with systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. So if a person has a blood pressure of 120/60, their estimated mean arterial pressure is 80 millimeters of mercury. A mean arterial pressure greater than 60 is needed to adequately perfuse and sustain the vital organs of an average person under most conditions. When the mean arterial pressure falls below this number for a period of time, the vital organs are underperfused and will become ischemic. Objective data, looking at the vital signs, observe the patient's general appearance, measure the blood pressure bilaterally. Take orthostatic blood pressures and heart rate while the patient is supine, sitting with legs dangling, and standing. Systolic blood pressure should not decrease more than 20 millimeters of mercury from the supine to the standing position, and the heart rate should not increase more than 20 beats per minute from supine to standing. Inspect the skin for color, hair distribution, and venous pattern. Look at the extremities for edema, dependent rubor, clubbing of the nail beds, varicosities, and lesions like stasis ulcers. Inspect the large veins in the neck, internal and external jugular, while the patient is gradually elevated from a supine position to an upright at 30 to 45 degrees. Distension and prominent pulsations of these neck veins is referred to as a jugular venous distension and can be caused by right-sided heart failure. Palpate the upper and lower extremities for temperature, moisture, pulses, and edema bilaterally to assess for symmetry. Look for edema by depressing the skin over the tibia or medial malleolus for 5 seconds. If pitting edema is present, grade it from 1+, mild pitting or slight brief indention, to 4+, which is very deep pitting, an indention that lasts a long time. Capillary refill is used to assess arterial flow to the extremities. Position the patient's hand near the level of the heart and squeeze a nail bed to produce blanching. Observe for the return of color. This should occur in less than 2 seconds, with normal peripheral perfusion and cardiac output. An artery that is narrowed or bulging may create a turbulent blood flow, and this abnormal flow can create a buzzing or humming termed a brewery. So auscultation of major arteries such as the carotid arteries, the abdominal aorta, and femoral arteries should be part of the initial cardiovascular assessment. Palpate the pulses in the neck and extremities for information on arterial blood flow. Assess the rhythm. Is it regular? Irregular? What is the force? It's important to palpate each carotid pulse separately to avoid a vagal stimulation and possible dysrhythmias. Compare the characteristics of the arteries on the right and left extremities simultaneously to determine symmetry. When palpating the arteries, rate the force of the pulse when it is felt. This is done using the scale of 0 is absent, 1+ is weak, 2+ is normal, 3+ is increased full bounding pulse. The rigidity or hardness of the vessel should also be noted. The normal pulse will feel like a tap, whereas a vessel wall that is narrowed or bulging will vibrate. The term for a palpable vibration is a thrill. The raised notch, the angle of Lewis, is where the manubrium and the body of the sternum are joined. It is palpable in the middle of the sternum. The angle of Lewis is the level of the second rib. It is used to count intercostal spaces and locate specific auscultatory areas. The 5 auscultatory areas include the aortic area in the second intercostal space to the right of the sternum, the pulmonic area in the second intercostal space to the left of the sternum. The tricuspid area is in the 5th left intercostal space close to the sternum. The mitral area in the left midclavicular line is at the 5th intercostal space. Erb's point is located at the 3rd left intercostal space near the sternum. The epigastric area lies on either side of the midline, just below the xiphoid process. An overall inspection and palpation of the bony structures of the thorax are the initial steps in the examination. Inspect and palpate the areas where the valves project their sounds by identifying the intercostal spaces and 5 auscultatory areas. Normally, no pulsations are felt in this area unless the patient has a thin chest wall. A valvular disorder may be suspected if abnormal pulsations or thrills are felt. Next, inspect and palpate the epigastric area. In a thin person, you may see the pulsation of the abdominal aorta, and normally you can palpate it here. Next, inspect the precordium, which is located over the heart, for heaves. Heaves are sustained lifts of the chest wall in the precordial area that can be seen or palpated. They may be caused by left ventricular hypertrophy, and normally no pulsations are seen or felt here. When the patient is supine, palpate the mitral valve area for the point of maximal impulse, also known as the apical pulse. This reflects the pulsation of the apex of the heart. The point of maximal impulse lies medial to the midclavicular line in the 4th or 5th intercostal space. If the PMI, or the point of maximal impulse, is palpable, record its position in relation to the midclavicular line and the intercostal spaces. When the PMI is below the fifth intercostal space and left of the midclavicular line, the heart may be enlarged. When auscultating the apical area, you should simultaneously palpate the radial pulse. A judgment about the rhythm, regular or irregular, is made while listening. S1 and S2 are heard best with the diaphragm of the stethoscope because they are high-pitched. The S1 is associated with closure of the tricuspid and mitral valves and has a soft lub sound. The S2 is associated with closure of the aortic and pulmonic valves and has a sharp dup sound. S1 signals the beginning of systole and correlates with the QRS complex on the ECG. S2 signals the beginning of diastole and correlates with the period immediately following the T wave on the ECG. Normally, no sound is heard between S1 and S2 during the periods of systole and diastole. The S3 heart sound is a low-intensity vibration of the ventricular walls, usually associated with decreased compliance of the ventricles during filling. The S4 heart sound is a low-frequency vibration caused by atrial contraction. It precedes the S1 of the next cycle and is also known as an atrial gallop. When cells are injured, they release their contents, including enzymes and other proteins, into the circulation. These biomarkers are useful in the diagnosis of myocardial injury and infarction. Cardiac-specific troponin is a myocardial muscle protein released into circulation after injury or infarction. Troponin is the biomarker of choice in the diagnosis of an MI. Creatinine kinase enzymes are found in a variety of organs and tissues and occur as 3 isoenzymes. These isoenzymes are specific to skeletal muscle, CKMM, brain and nervous tissue, CKBB, and the heart, CKMB. The CKMB elevation is specific for myocardial injury or infarction, and it can rise between 3 to 6 hours after symptom onset, peak in 12 to 24 hours, and return to baseline within 12 to 24 hours after MI. The peak level and return to normal can be delayed in a person who has had a large MI. Levels will drop more rapidly in patients who are quickly and successfully treated. Myoglobin is a low molecular weight heme protein found in cardiac and skeletal muscle. Myoglobin elevation is a sensitive indicator of a very early myocardial injury but lacks specificity for MI. Its usefulness in diagnosing an MI is limited. Correct interpretation of diagnostic tests requires consideration of the time from the onset of the symptoms with the time of the expected presence and elevation of the biomarkers. Additional data, patient symptoms, history, and ECG changes complete the diagnostic picture for the patient with suspected myocardial injury or MI. C-reactive protein is a protein produced by the liver during periods of acute inflammation. An increased level of C-reactive protein is an independent risk factor for coronary artery disease, and the level may also predict the risk for future cardiac events in patients with unstable angina and MI. Homocysteine is an amino acid that is produced during protein catabolism. Elevated levels can either be hereditary or acquired from dietary deficiencies of vitamin B6, vitamin 12, or folate, and linked to a higher risk for coronary artery disease, peripheral vascular disease, and stroke. It is recommended that testing be performed in these patients with a familial predisposition for early coronary vascular disease or a history in the absence of other common risk factors. Cardiac natriuretic peptide markers. There are 3. Atrial natriuretic peptide, ANP, is from the atrium. B-type natriuretic peptide, BNP, is from the ventricles. C-type natriuretic peptide is from endothelial and renal epithelial cells. The BNP is a marker of choice for distinguishing a cardiac or respiratory cause of dyspnea. Serum lipids consist of triglycerides, cholesterol, and phospholipids. Triglycerides are the main storage form of lipids and make up about 95% of fatty tissue. Lipoproteins. Although formed in most cells, phospholipids usually enter the circulation as a lipoprotein synthesized by the liver. Serum lipids circulate in the blood bound to protein, and they are often referred to then as lipoproteins. Different classes of lipoproteins contain varying amounts of the naturally occurring lipids. These include chylomicrons, which are primarily exogenous triglycerides from dietary fat, low-density lipoproteins, LDLs, which is mostly cholesterol with moderate amounts of phospholipids, high-density lipoproteins, HDLs, about 1/2 protein and 1/2 phospholipids and cholesterol, and then very low-density lipoproteins, which are primarily endogenous triglycerides with moderate amounts of phospholipids and cholesterol. A lipid panel usually measures cholesterol, triglycerides, LDLs, and HDLs. Elevation in triglycerides and LDLs are strongly associated with coronary artery disease. An increased HDL level is associated with a decreased risk of coronary artery disease. High levels of HDL serve as a protective role by mobilizing cholesterol from the tissues. Although the association between elevated serum cholesterol levels and coronary artery disease exists, a measure of total cholesterol alone is not sufficient for an assessment of coronary artery disease. A risk assessment is calculated by comparing the total cholesterol to HDL ratio over time. An increase in the ratio indicates increased risk. This provides more information than either value alone, and a patient must fast before blood is drawn for a lipid panel to remove the effects of a recent meal. The chest X-ray shows the heart size and anatomic changes in individual chambers. It records any displacement or enlargement of the heart, presence of extra fluid around the heart, like a pericardial effusion, and pulmonary congestion. There are many types of ECG monitoring, including a resting 12-lead ECG, ambulatory ECG, and exercise or stress testing. Continuous ambulatory ECG, known as Holter monitoring, can provide diagnostic information over a greater period of time than a resting 12-lead ECG. An echocardiogram uses ultrasound waves to record the movement of the structures of the heart. In a normal heart, ultrasonic sound waves directed at the heart are reflected back in typical configurations. The echocardiogram provides information about abnormalities of valvular structures and motion, cardiac chamber size and contents, ventricular and septal motion and thickness, pericardial sac, and ascending aorta. The ejection fraction, or the percentage of end diastolic blood volume that is ejected during systole, can also be measured. The ejection fraction provides information about the function of the left ventricle during systole. Stress echocardiography is a combination of treadmill and ultrasound images and evaluates wall motion abnormalities. This test provides information of an exercise stress test with the information from an echocardiogram. Transesophageal echocardiography provides a more precise picture by removing interference from the chest wall and lungs. It is contraindicated if the patient has a history of esophageal disorders, dysphagia, or radiation therapy to the chest wall. Patients will require sedation during a transesophageal echocardiography. Nuclear cardiology. One of the most common nuclear imaging tests is a multi-gated acquisition, known as a MUGA, and it provides information on wall motion during systole and diastole, the cardiac valves, and ejection fraction. Cardiovascular magnetic resonance imagery can detect and find areas of an MI in a 3D view. It is sensitive enough to find even small MIs that are not apparent with single photon emission CT imaging. It also plays a role in prediction of recovery from MI and in the diagnosis of congenital heart and aortic disorders and coronary artery disease. Cardiac tomography, or CT, is a heart imaging test that uses the technology with or without contrast dye to see the heart anatomy, coronary circulation, and great blood vessels, like the aorta, pulmonary veins, and arteries. Coronary CT angiography is a non-invasive test that can be done faster than a cardiac catheterization with less risk and discomfort to the patient. But when a cardiac catheterization is done, interventions like angioplasty or stent placement can be performed if coronary blockages are found. A calcium score screening heart scan is used to find calcium deposits in the plaque in the coronary arteries, and it can detect early coronary calcification before symptoms develop. Cardiac catheterization provides information about the coronary artery disease, coronary spasms, congenital and valvular heart disease, and ventricular function. With injection of contrast media and fluoroscopy, the coronary arteries can be seen and the chambers of the heart can be outlined and wall motion can be observed. Coronary angiography is done with left-sided heart catheterization. The catheter is positioned at the origin of the coronary arteries and contrast media is injected into the arteries. Patients often feel a temporary flush sensation with the dye injection. The images identify the location and severity of any coronary blockages. Complications of cardiac catheterization would include bleeding or hematoma at the puncture site, allergic reaction to the contrast media, looping or kinking of the catheter, infection, thrombus formation, aortic dissection, dysrhythmias, MI, stroke, and puncture of the ventricles, cardiac septum, or lung disease. Intracoronary ultrasound, also known as an intravascular ultrasound, is an invasive procedure performed in the catheterization laboratory with a coronary angiography. The health of the arterial layers is assessed, including the composition, location, and thickness of any plaque. Intracoronary ultrasound can evaluate vessel response to treatments such as stent placement and atherectomy, as well as any complications that may have occurred during the procedure. Nursing care is similar to that followed for cardiac catheterization. Fractional flow reserve is a procedure that is done during a cardiac cath. It involves using a wire that can measure pressure and flow in the coronary artery. It helps to determine the need to perform an angioplasty or stenting on non-significant blockages. Electrophysiology study records and manipulates the electrical activity of the heart using electrodes placed inside the heart chambers. It provides information on the SA node, AV node, and ventricular conduction. It is particularly helpful in determining the source and treatment of dysrhythmias. Patients with symptomatic supraventricular or ventricular tachycardias may be at risk for sudden cardiac death. Information from an electrophysiological study help to make an accurate diagnosis and guide treatment decisions. The catheters are inserted in a manner similar to a right-sided heart catheterization. These catheters are placed at specific anatomic sites within the heart to record the electrical activity. The nursing care of patients after an electrophysiological study is similar to the care of patients after cardiac catheterization. This includes continuous ECG monitoring and frequent assessments of vital signs and the puncture site.